I'm Vic Senese, and this is UroNurse News. Don't forget to like and subscribe. An important development in prostate cancer screening, a new predictive model that may change how we interpret PSA results at the very moment of screening. Think about that. This is not about diagnosing cancer, it's about predicting long-term prostate cancer mortality risk earlier, smarter, and more personalized. Researchers led by Dr. Patrick Lewicki at the University of Michigan report in the Annals of Internal Medicine that PSA screening is most effective when it's risk-adjusted, not one-size-fits-all. And until now, we've had very few tools to do that. So what did researchers do? The investigators developed an externally validated prostate cancer-specific mortality model, also called the PCSM model. They started with PSA data from over 33,000 men with no prior history of prostate cancer enrolled in the PLCO cancer screening trial between 1993 and 2001. Now, to confirm their findings, they validated the model using PSA data from nearly 175,000 men in the Veterans Affairs healthcare system. That's a very large, very real-world data set. The typical participant was about 62 years old with an average BMI of 27, and about two-thirds had a history of smoking. Median PSA level at first screening were around 1 nanogram per milliliter, numbers that many people would consider normal. What factors did the model use? The PCLO model focused on 3 key inputs: PSA level, family history of prostate cancer, and race. Simple inputs but powerful when combined. Over long-term follow-up, 501 men in the derivation group died from prostate cancer. 1,933 men in the validation group died from prostate cancer. The model estimated long-term mortality risk, not just short-term cancer detection. At nearly 30 years after screening, the median prostate cancer mortality risk was about 1.6% in the PLCO group. At 20 years, the risk was about 0.75% in the VA population. So how did this model perform? Well, the PLCO model consistently outperformed the commonly used prostate biopsy collaborative group model, or the PBCG. It showed better discrimination, meaning it was more accurate in identifying who would or would not die from prostate cancer over time. This advantage held true over decades of follow-up, before age 85, and even among men already classified as high risk by other models. That's clinically meaningful, a potential PSA stop signal. One of the most interesting findings was the identification of a 0.5% mortality risk threshold. Men below this threshold could be considered for discontinuing PSA screening. That group represented about 17% of patients, yet they still had a 4% lifetime risk of prostate cancer mortality before the age of 85. So, this could reduce unnecessary testing while keeping our focus on men who truly benefit. Why this matters clinically? We've long known that PSA alone is imperfect, or imperfect if you say it that way. Some men with PSA values under 3 nanograms per milliliter still harbor aggressive disease. That's where advanced risk tools really play their part. Data from the Stockholm 3 blood test trial suggests that combining PSA with advanced biomarkers, genetics, and clinical risk data can improve detection of high-risk cancers while reducing overdiagnosis of low-risk disease. Men with elevated Stockholm 3 scores were far more likely to experience high-risk biochemical recurrence, a known predictor for prostate cancer-specific mortality. Risk stratification is the future. This new model moves us closer to personalizing PSA screening, where decisions are based on long-term risk, not fear of a single number. PSA screening doesn't need to be abandoned. It needs to be used smarter. For patients, providers, and policymakers, this research supports a shift towards risk-adjusted screening strategies that balance early detection with harm reduction. Still, this update represents a major step forward. Medical AI that can see, read, listen, and reason. The future of healthcare technology is no longer theoretical. It's being built right now. Tonight, on Dr. Jeff Talks About Sex and Intimacy, Dr. Jeff sits down with licensed marriage and family therapist Dr. Rose Hanna for an eye-opening conversation about how our digital world is reshaping relationships. Phones, devices, and constant distraction are becoming the biggest competitors for emotional connection, eroding presence, empathy, desire, and the feeling of truly being seen. If you've ever felt distance from your partner, even when you're together, this episode is for you. Tune in tonight for honest insights, practical strategies, and real talk about intimacy in the age of technology. Don't miss it. drjeffsextalk.com. Tomorrow on UroNurse News, doctors are setting the record straight on 5 women's health myths that millions still believe. From breast cancer screening to menopause to heart disease, what you think you know may not be the full story. Join me for evidence-based answers every woman should hear.